My name is Greg Honeycutt. I'm one of the pulmonary critical care physicians here at Houston Methodist Willowbrook Hospital. I'm also the medical director of our Lung Nodule Program here at Willowbrook. I have been a physician for 18 years now. I trained at Baylor College of Medicine for medical school, as well as residency and fellowship, and have been in practice since 2012. And I've been part of the Houston Methodist family since 2017. For about the past 12 months, we have been working on growing our Lung Nodule Program, which is focused on early detection as well as diagnostic and then therapeutic options for patients who present with lung nodules, of uncertain etiology.
Typically, the only way to find cancer early is screening. Unfortunately, a lot of these, incidentally, they go for something else to the ER and they do a scan and they find something. In the past, there wasn't a clear pathway for them, and a lot of them get missed, that they had some spot, nobody addressed it. So we wanted to not miss these, and that's part of those incidental findings. Anything that may be something significant need to be evaluated and discussed.
That's the idea of an incidental lung nodule program. The best way of curing cancer is to find it early when you didn't even know you had it. And that's what these incidental nodules are. And if we're aggressive and we pursue them, we're going to find stage 1 cancers and cure them long before they turn into 3 or 4 cancers that we can't do much about.
We started seeing patients for the first time back in January of 2024, and the principle was simple enough. How do we triage and then ultimately expedite the workup, both diagnostic and therapeutics, for patients who were found to have a lung nodule? Well, I'll tell you what, big guy, let me have a quick listen to you. Let's see how you sound. Today, we're going to be seeing patients who were referred for either a known lung nodule, perhaps even patients who have a pathologic diagnosis. For example, our first patient has a known history of small cell lung cancer, but now has a lung mass that's enlarging. And the concern is that he may have either a recurrence of his small cell cancer, or could this be some other process? Oncology would like us to re-examine his imaging and potentially obtain additional tissue diagnosis. So this is the area that they were concerned about, and we were wondering, because this is the same area that I biopsied before. The second time that it had come back is the organizing pneumonia. CT imaging has become so advanced and so high resolution at this point that oftentimes, we're able to detect spots of, only a few millimeters in size. Went from 5.3 to 6.3. So it's about a centimeter, a little bit larger, about like that. What I would probably try to do is I'd come in around maybe on this side, around the perimeter. So I'll try to sample around the exterior of that. And then our goal is obviously to help patients and other clinicians alike distinguish between nodules that represent a benign process versus nodules, that may represent a malignancy, that needs immediate attention. You just want to know, okay, is this something we can resolve with medical therapy? But if it's not completely resolving with medical therapy, you just have to ask the follow-up question, which is, what else could be triggering it, and hence the question of biopsy. Let's see what's going on. We'll cross the bridge when we come to it.
Okay.
Always a pleasure, young man.
Mm-hmm.
Ma'am.
Thank you.
You betcha. Good to see you guys.
You too. All right.
All right.
Thank you.
Thank you, Dr. Honeycutt.
You betcha, guy. I had wanted to be a physician when I was younger. I grew up watching, television shows such as, ER. My late grandmother had actually been a nurse for about 50 years, so I had some early on exposure to healthcare. 6 weeks out, so we can document she completed antibiotics. But as happened when I got into internal medicine training later on, I happened to do some rotations in pulmonary and critical care. Really found I had a passion for it. I find myself learning something every day. There's every opportunity for growth in terms of knowledge and experience, simply because there's so much that we still don't know. Knock, knock. Mr. Cook.
Yes.
Greg Honeycutt, pleased to meet you, sir. How are you? Ma'am, how do you do?
I'm Sharon, I'm his daughter.
So the second patient we're seeing today, gentleman, 84 years old, referred to me for consideration of biopsy of an enlarging right upper lobe pulmonary nodule. that has not really showed up very well on PET CT, but the possibility is that he may have a lung cancer that's very slowly growing. He also has COPD and requires home oxygen. As I understand it, had you smoked at one point? Is that correct?
Oh, yeah.
How many years in total did you smoke, my friend?
70.
70 years? There seems to be a higher incidence of primary lung cancer in patients who have COPD, as either a primary exposure to tobacco smoke, or occasionally in patients who have no smoking history but have secondhand smoke exposures. So the discussion that we're having with him today is, should he proceed with doing ion navigational bronchoscopic biopsies? And we told him, his schedule permitting, the plan will be, let's take him to the operating room next week, a week from today. If I can find one of these guys early, and it does turn out to be cancerous, we have a much better chance of being able to get rid of this thing altogether. And the sooner we can make a diagnosis, the sooner we know what to do next. We tend to see our patients in this particular room, just a little bit more space. And we have an iPad that is, mounted on this particular stand, has a Bluetooth speaker. And what this enables us to do is, patient is seated here, I'm sitting here, interviewing the patient, examining the patient in person. But if we have other specialists, that we need to conference in, they're able to see the patient virtually, establish care with that patient, interview them, order any additional workup that needs to be completed from their perspective. Essentially, once a patient has a biopsy, and if it returns malignancy, the patient has already been seen by, for example, thoracic surgery, medical oncology in the same encounter. They're now being followed by the oncology nurse navigator.
So I'm sure Ms. Jackie explained everything. You'll be having probably a CT scan and a pre-op.
We put an emphasis on efficiency, on not taking 60 days to go through 3 or 4 different doctor's visits and more imaging steps. We can get the patient seen, the nodule evaluated, biopsied, and treated often in less than 2 weeks. And that's groundbreaking. That's unheard of.
So it improves basically our ability to treat patients. They know that their case is discussed. It's a whole team that looked at their case and that they came up with this recommendation. They feel confident that it was based on really a scientific approach to it.
Really recognizing who the candidate is
Today, we had the opportunity to go to the operating room to perform ion navigational bronchoscopic biopsies on a gentleman named Mr. Oliver, who has underlying emphysema and pulmonary fibrosis. He had a PET scan earlier that showed that his nodules in the top of his right lung were both lighting up and were suspicious for cancer. That's a hard dot there. The ion navigational bronchoscopic biopsies, that we are now doing, enables what's called an ion protocol CT scan to be fed into the computer modeling software, and then, as opposed to just seeing a 2D, image of the patient's airway anatomy, in real time it's able to generate a 3D image, so that it can actually be followed, analogous to a trail of breadcrumbs, if you will, to go from the central airways out into the periphery of the lungs, to be able to sample a lesion. So this is the lesion that we're looking for. We know, okay, tip of the catheter is going to be right here next to the lesion, and we just check it in 3 different planes. It has been a game changer in terms of our ability to access lesions that otherwise would be inaccessible to standard bronchoscopic techniques. What's actually new for us is called a cryoprobe, and it enables you to obtain a frozen sample of tissue by placing the probe inside of the nodule in question, freezing it, and then you're able to extract a sample to send that to the lab. You see that little thing on the tip of it is your sample. And so then what we do is I hand it to these gentlemen, and they take this little piece of tissue and they scrape it off, they smear it on the slide a little bit, and then we send some of this stuff to pathology for them to go look at. So, it has really improved our diagnostic yields, now that we've been using this new technique. I think my assessment, of the Lung Nodule Program is it's very, very satisfying, certainly on a personal or professional level. And it has been likewise very satisfying to meet with patients, who we were able to detect early, diagnose early, treat early. If we can bring together different specialties to see a patient, with regards to a lung nodule, all at the same time, as opposed to sequentially, the speed with which we're able to obtain their diagnosis obviously is reassuring to the patient, and our goal throughout has been to provide them the best information and medical recommendations, and then ultimately to move the patient's case along to the next phase of their care.